Good morning. I am Marc Sirvent, vascular surgeon from Granollers, Catalonia. Well, Cre8 below the knee is a balloon expandable drug-eluting stent with a very distinctive design. First, it's a polymer-free platform that avoids all the well-known drawbacks related to the presence of a polymer interface with blood flow or vessel wall, such as a persistent inflammation and late thrombosis. Secondly, the drug is contained in reservoirs that control its release, perfectly matching the restenosis cascade. And especially interesting is its ampholimous formulation, which means the combination of sirolimus with fatty acids, very useful in diabetics population, because these patients have an overexpression of the fatty acid receptors that allows to have a higher drug concentration inside the cells of the diabetic patients, which is our main focus. Moreover, the surface of this stent is coated for an ultra-thin film of pure carbon, reducing the inflammatory process of the foreign body reaction. And finally, Cre8 has a very good visibility due to the radiopaque markers on the edges, making the deployment easier, and is the longest of its kind, being this fact very useful when we face long lesions. Well, before Cre8 stent was launched, we used other drug-eluting stents in the peritoneal vessels. However, when Cre8 became available, it quickly replaced them because we realized that it works amazingly well. And this is due to its several unique clinical features that ensure effective neointima suppression and rapid endothelialization, representing a significant advance in stent technology. So this stent has been created to address challenges in complex lesions, specifically in diabetic patients, as described in the previous question. Well, many experiences with Cre8 stent have been presented in specific sessions on CLI, diabetic foot, and different congresses in the last 10 years. But we can find few articles in the literature about this stent in below-the-knee setting. So regarding the evidence in the infrapopliteal arteries, everyone knows that this outperforms bare metal stents efficacy, as stated by randomized controlled trials like Destiny, Yukon, etc. But these trials have always included too easy patients which don't represent real-life treatments in this area. So to demonstrate these benefits in real patients, more complex lesions and patients should be considered, on top of also considering larger randomized control trials, looking to evaluate different strategic approaches to below-the-knee treatment. So following these arguments, our data on Cre8, which is pending to publish, are focused on real-life below-the-knee lesions and patients to better reflect the benefits that this device can bring during cath lab everyday activity. Our study is a prospective single-center registry to evaluate the efficacy and safety of the Cre8 stent in our population, which is 100% CLI, 90% RF4 class 5 and 6, and 10% 4. The key finding is to verify that Cre8 works awesomely well in this territory, in these complex patients with long-term follow-up. So we stented lesions up to 13 centimeters in length using 4 Cre8s. We show a 3 years primary patency of more than 73%, a 3 years limb salvage rate of close to 81%, and 92% of the patients kept their ulcers healed at 3 years. So we have some patients with more than 6 years of follow-up. And I think they are excellent results with long-term follow-up. Therefore, in our experience, the use of this stent in this infrapopliteal lesion significantly inhibit vascular restenosis, obtaining excellent encouraging long-term patency and lip salvage rates, as well as high ulcers healing rate are achieved in patients with CLI. Today, in below-the-knee lesions, drug-eluting stents are the only proven technology capable of improving outcomes such as limb salvage, ulcer healing, patency, etc., as several multicenter RCT show with the highest level of evidence, which is 1A. All these outcomes have been very encouraging in our large experience in the most complex populations studied so far, as I mentioned before. So according to this data, we can state that these are superior compared to the other treatment modalities in short to medium lesions. So, in my opinion, future clinical trials should focus on multicenter perspective head-to-head with other modalities of treatment in randomized controlled trial, including large cohort of real-world patients, which means longer and more complex lesions in more complex patients. And obviously, a long-term follow-up would be welcome. And other room for research maybe is are longer stents, including self-expandable stents and bioobservable stents.